Hi, I'm Stephanie Shelton, and this is Conversations on Health, How We Get There, episode 26. Now, once again, it's open enrollment time for Medicare, which runs for just 6 weeks each year from October 15th until December 7th. Millions more Americans who don't get health insurance through their jobs or Medicaid can find or change so-called Obamacare plans from November 1st through January 15th of next year. So in this episode, we're concentrating on the changes to Medicare for 2025. We'll catch you up with the Affordable Care Act changes and their relationship to the state-run Medicaid coverage in the next episode. This is hard information you can use right now, and you should use it. We're also taking a look at the effect of these Medicare changes on private work-related insurance plans, which are quite likely to make adjustments for 2025. Now, if you need a primer on how all these programs actually work, check out episodes 14 and 15, and I'll include a link in the show notes. Dr. Stephen D. Culler, our expert from those earlier shows, was kind enough to come back again for this update. He's an associate professor at the Rollins School of Public Health and affiliated associate professor at the Guazetta Business School at Emory University in Atlanta. Steve, thank you so much for coming back and doing a quick update on the enrollment period for Medicare for this year, and also in our subsequent podcast next month for the Obamacare and Medicaid, which to me is even more complicated. So in terms of Medicare, what would you say is the most important change for 2025? And I'm curious to see if it's the same one I think it is.
Okay. Well, I think that probably the one that has had the most press is the drug pricing negotiation experiment that we just completed about a month ago, where the CMS picked 10 drugs and actually negotiated with the different pharma companies that had the patents to those drugs to come up with a price that Medicare was going to pay, which is, again, the actual first time Medicare has ever negotiated drug prices. Then there's some other things that have happened. Again, I think that the subsidy for the Obamacare, which we'll talk about the next time, was actually extended to through the year 2025. So that means there'll be one more year where the subsidies that most people were getting are bigger than they were in the original bill. And then the probably biggest change to Medicare alone is the drug price cap of, or out-of-pocket cap of $2,000 for Medicare beneficiaries that have a Part D drug plan or a managed care plan with a Part D plan embedded in the managed care. And so that's another major thing. And then there's some minor things. There's Medicare is now going to pay for all vaccines of any kind. They extended it for permanently, I believe, this time.
Okay.
Yeah.
Okay. All right. So the main thing I think that sticks out to most people who have any amount of drugs is that $2,000 cap, and that it sounds too good to be true.
Yeah. So yeah, it is true that there's a $2,000 out-of-pocket cost for individuals. And again, for people who are using extremely expensive drugs that cost multiple thousands of dollars per month, that's even in the old plan, there was never a complete cap. So you only paid 5% after some point, but that's still a significant amount of money and that was coming out of pocket. So now you really are capped at $2,000. if you have prescription drugs. And again, any drug covered under your Part D plan has a $2,000 cap in total. You're out of pocket. If you're taking a drug that's not covered under your plan, then it's not capped. So again, it's much more important now to make sure that when you look at the plan, that you pick a plan that includes whatever drugs you're taking.
which
Or
is
if you
still
aren't
Russian.
taking any drugs at all, you need to take one that sort of does the most general across the board type thing.
Yeah, because it's still Russian roulette. You can start out the year taking no drugs and end
Yeah.
up with something you had no idea you were going to get
Yeah.
and be stuck with an expensive
Yeah,
drug. And then
so
you are
yeah,
stuck,
it's
right?
very possible that in any one given year, if you're a low drug user, you could end up with higher than $2,000 out of pocket. But then the next enrollment period, which is actually October 15th to I think December 5th or something each year, you can change plans. So you can correct that problem
Right, but
in
you're
one
stuck
year.
for 1 year and you could
Yeah,
be stuck with thousands of
yeah,
dollars.
yeah. And then again, I always say that, nothing's free. So again, one thing we should expect is that over time, the prescription premium is going to go up. Again, I read an article today that actually said essentially the cost to the drug companies is basically $250 billion as a result of this cap. So again, that's almost twice what the drug companies were paying for drugs before. So again, that will eventually happen. The current administration has actually running an experiment this year that could potentially change the price of drugs, and so they're going to actually pick up quite a bit of that cost this year. So I don't think prescription drugs will go up much this year, but in the future they could go up much more.
And I think there was also this $2,000 cap, as I recall from reading it last year, actually, is going to rise with inflation. It will
Yes,
not
it will
stay that way.
eventually. Yeah, yeah,
And the other downside to
yeah.
that 2000, and there is there's always a downside, right?
Yeah. Yeah. Well, I mean, the second downside is that, again, depending on how they structure the way plans get paid. These are the drug plans. I mean, they may drop out of the market. So again, if you're in a rural area and didn't have a lot of plans to begin with, it may be hard now to find a plan in your area that you can actually use the drug plan for. I think the other thing you're going to see is that you know, uh, there there's probably going to be, especially in the Medicare Advantage plans, there's probably going to be some reduction in some of the freebies that were part of those plans, like gym membership and eye care and dental care
Right.
that Medicare doesn't cover in general.
All
Yeah,
right, and we'll talk about that a little more when we go into the Advantage plans, which
right.
require a little more time.
Yeah,
Um, the other thing that I saw it on the CMS, the Centers for Medicare and Medicaid. I saw it on their website, and I've already seen it in at least one drug plan from a friend. That the premium for the drug plan may go up. In this case, it did go up. It went up from almost nothing, to a little bit more money, the premium.
right.
That your copay may go up. In this case, it doubled and tripled.
Yeah,
So that's already happening.
yeah, yeah.
The drug plans are not taking this lying down. Let's put it.
No, well, and again, I think it's a ton of money if you actually look at, since they pay a lot of the high cost drugs, most of the Medicare beneficiaries in the old plan without this cap was only paying 5%
Uh,
of the cost. So that was all covered by the premium. And so now that's some of that in the way the legislation was passed is going to be passed back to the drug manufacturer and the benefit managers, but most of it is just going to be on the drug insurance companies. And eventually, as I say, premiums are going to go up.
I think you told me when we were just discussing this that eventually all premiums will go up.
Yeah, yes, they will. Yeah,
Yeah, well, it's America.
yeah,
Um, the other big thing, which is already in force actually, is the coverage of at least one weight loss drug by Medicare.
Yep.
And the potentially, as others are authorized to treat other conditions other than obesity, the coverage of more of them.
Yeah, yeah. And again, what's going on there is, Medicare has agreed to cover one of the drugs that has heart benefits. And so again, if you look at that kind of thing with obesity, I always do these little numbers. There's 65 million people in the Medicare program on any given day. Yeah. And if a quarter of those people are actually qualified to take that drug because either they're obese and with heart problems. If you just think about that, that's literally 16.5 million people at $1,300 a month times 12 months. That's like $15,000 a year for those people times the 16 million comes out to basically $250 billion a year in just that one drug. Do you
One,
have any idea what the total payout was last year for Part D?
no.
It was 120 billion.
Oh
So it
my goodness.
literally would double what we paid for drugs last year.
Unbelievable.
Yeah, and just shows you how a relatively inexpensive drug, $1,000 a month, because there's lots more expensive, but a moderate price drug with a lot of people ends up being a huge payout.
Wow.
And
That's
that's another thing that those drug companies are going to have to cover. So again, it's going to be hard to know down the road whether it's the $2,000 cap or whether it's coverage for obesity drugs that are going to drive the cost.
and the last figure I've seen, this is not a Medicare population, but a population in general,
Yeah,
is that 43%, this is from
yeah.
the federal government,
Kaiser Found. Yeah,
43% of the US adult population is obese.
yeah.
And that
And
doesn't
that
mean they all have heart issues, but the possibility is there.
Well, I think in the younger people, it's more the combination of obesity and diabetes, and then heart disease and all the other stuff that goes with diabetes. But yeah, I think that it's even going to be a bigger decision for private employers on what they're going to cover, if anything, and if they're going to cover, is it going to be staggered? Is it going to have a total payout block at some point? They're only going to pay for the first $5,000 a year, whatever it might be. There's lots of ways to manage those programs and trade off between copays, coverage, and then total payout. Yeah.
Doesn't Medicare, in a sense, if they push prices down, isn't that kind of pushing down prices overall, even for the, prices for the drug plans, but for the private sector,
Yeah.
doesn't that kind of push them to cover some of these drugs that they may not have covered before, like the obesity drugs?
Yeah. Yeah. I would say that probably in terms of coverage historically, once Medicare covered a service, most private insurers covered those services. Drug plans have always been a little different. I can remember back, I'm old enough to remember when AIDS was new and there was multiple years where they didn't, most US companies didn't cover AIDS, even though it was covered by most everybody else. So again, I would not say that that's a surety. I think that at some point, corporate America cares about the bottom line and they're going to put their package together so that they can provide some benefits for all their employees and I think that again there's still not this universal belief that obesity is a illness and therefore not everybody deserves coverage just because you're overweight, right?
But if they do start covering drugs like the obesity drugs,
Yeah,
there are bound to be other drugs that fit into the at least expense category.
right, yeah,
Don't they, in a sense, and aren't we maybe looking into a restructuring of how these plans are paid for? Like if you're an employee,
yeah,
you may still get a plan for a reasonable amount of money, but if you have a family, that
Yeah.
might change?
So there's probably two or three things to that make the private sector different than Medicare. So Medicare, as long as you're alive, you're covered. In the private sector, you got to be healthy enough to work. And so some of these expensive cancer drugs that you have to stay in a hospital for 3 months, you can't work. And so you lose your benefits when you get those. And so that does on the backside for the employer, a very sick person typically ends up losing their insurance because they can't stay employed.
Whoa, I didn't know that. That's
Yeah,
right.
yeah. Yeah, I mean there is some COBRA coverage, but it's less than a year, and for most people, once you get that sick, you pretty much are out of luck. So that's sort of helps save the money. Obesity is a little different because these people aren't critically sick, and so they can still work. And so again, I think it's a much tougher decision for the employer on how much money they want to pay out for that coverage, and given all the other things that they could do with that money in the healthcare.
I think when we were talking about this, you suggested that one of the ways they might deal with it, if you are covered, family coverage, a couple of kids and a wife or husband,
Yeah,
that their coverage might actually cost something more than what it
yeah,
costs now.
yeah. So that's a fairly easy way to keep the company's portion of the premium bill much more stable because you can cover only employees. Now that hasn't been historically what the US population is experienced, but if you remember in the original Obamacare, there was going to be a private exchange for employers that where people who were employed and had insurance could go, and the employer would pay their share of whatever it was. But that never actually got developed and has never been used. But again, it may be something that Congress looks at, especially over this obesity drug that's could potentially just cost these employers billions of dollars a year.
A lot of big decisions that have to
Yeah, yeah. Well, I think the scary thing about the obesity drug right now is that it still appears that even if you lose weight, as soon as you stop taking the drug, you gain that weight back. And so it hasn't shown that it changes lifestyle and eating behavior. It just doesn't make you hungry, so you don't eat as much. But
I
the
think
minute you take on,
what
yeah,
I saw was that they now have figures going out about 3 years.
yeah,
And for most people, they did gain all or some of the weight back, and a few people didn't,
yeah, yeah,
you relatively speaking, in the
yeah,
test, and they don't know why.
yeah,
So
right.
there's so much they don't know about it.
You're right. And we don't have any idea what the long-term effects of the drug are. So again,
No.
if this is something you're going to take for 10 years, we'll know in 10 years whether it's really bad for you or not. So we got a lot to learn on that drug,
Yeah,
but again, it'll right now we're sort of doing what America always does is we got lots of experiments going on as different companies have done different benefit designs. And then there's the whole richer population in the United States that's just decided they're going to buy it on their own, whether they have coverage or not. So,
right.
so we'll soon have some idea, how well the drug works over time.
All right, I think we have one other thing to look at with Medicare, and just basically point it out
Yeah,
that starting in 2025, the Medicare plan provides the option to people with Medicare prescription drug coverage. I'm quoting now from CMS, to spread the cost of their prescription drugs over the calendar year rather than paying the full cost of the drug right away.
yeah. So yeah, so it looks like Medicare is going to get in the lending business, but essentially I mean, again, it's for people who are using drugs at a high level. That means that instead of having a $2,000 bill due in January, you now have a $167 bill for the next 12 months to pay off that $2,000 drug. So or coverage. So again, it's nice for the people who are high level. The people who never make it to the $2,000 cap, probably it won't matter to them at all.
All right. So is there anything, the one other thing which is changed to telehealth coverage, and I guess
Yeah,
it's going to be pretty universal, that it's not going to be universal anymore.
right. So in the main Medicare program, Part A, B, and D, the old traditional one, it's going to go away at the end of the next year. Or is it this year? I can't remember.
At the end of this year,
End of this
January
year.
31st.
Yeah, unless you're in a rural area and a couple other mental health issues.
Right.
But the Medicare managed care can still use telehealth if they want. So again, CMS will probably run some experiments to see how popular that really is among the relatively, people who do managed care advantage, and that's half of the Medicare population. So I think that we'll know better in a year or two whether or not telehealth has any future at all in the Medicare program.
All right, now we should give some attention to the Advantage plans.
Yep.
Um, I think you said this last year, and I know you're going to say it again, that most people have no idea what they're getting caught up in when they take an Advantage plan.
Right. Yeah. So again, I think that most people think that their Medicare coverage is identical to the traditional plan if they take a Medicare Advantage plan. That is not true. The plan has some flexibility to restructure things like rehab care and skilled nursing home care and home health care. And so again, there's now that happens. You get sick and you have a stroke unexpectedly and you need rehab. And under the traditional plan, as long as you were making progress physically or speech wise, you were covered. Under most of these managed care, there is a limit to the number of days you can stay. And then you have to petition CMS or the insurance company, and there's a process to actually get more. And it's a relatively lengthy process, and you often tend to have to pay for those days on your own until there's a decision made. So again, I think that those things are becoming more and more important because historically the people who did Medicare Advantage were relatively healthy compared to the rest of the people. And so there weren't a lot of skilled nursing home and rehab days. Now all of a sudden when you cover half the population, you can't get all the healthy people. So I think that we're seeing more and more examples in the news of people who were denied coverage by their managed Advantage plan. Yes.
And there are other things about the Advantage plan that I don't think most people realize. In regular Medicare, original Medicare, you can go to any doctor you want to go to,
That's
any
correct.
hospital you want to go to.
Yeah.
You can't in most of the Advantage plans.
Yeah. So most of the Advantage plans are run just like sort of I always called it the great HMO experiment in the early 90s in this country, where you had a very, very narrow panel of doctors that you can go see. And again, I think that again, as people now are less healthy enrolling in these Advantage plans, they're finding out very quickly how narrow some of the networks are. And again, that's really, really important for people in some of well, I always say anybody west of the Mississippi River where it might be 200 miles to the doctor
Yeah.
and
Yeah.
that's in your plan, maybe 50 miles, but yeah.
And the other thing is there are not going to be so many of them, as you mentioned earlier. Humana, for example, the second largest Advantage plan issuer, is dropping out of the Advantage plans, and I think 13 markets. And then they also said that there are likely to be fewer their plans to choose from in other markets because they didn't make so much money off.
Right. Okay. Well, again, if you actually go back, so I always laugh about this. I mean, Congress wanted the Medicare Advantage plans to survive. So they've always set payment. CMS has done done that so that they were making money, and a little more money than they made on the private business. I think that now with half of the market, that actually, I saw last year where the Advantage plan per enrollee spent more money. Congress spent more on the Advantage premiums than they did in the traditional plan. So I think there's a couple things they're going to do. They're going to make the formula to determine the actual premium that they subsidize a little less advantageous for the plan. And I think that they're also going after, and this is a whole nother discussion, they're going after the risk adjustment model. And there will be a new one out that makes it much, much harder to get paid a lot more for people who aren't really, they have conditions that aren't getting treated,
Right. I think that's this Humana thing
Yeah.
that I read. A review plan's annual notice of change. You will get a mid-year statement showing the available benefits that you haven't used.
Yeah. Yeah. I think that what they're going to do is move, however they want to call it, value-based care, to that premium is going to be based on some outcome measures for that person, plus the actual dollars they spend, so that you don't absolutely get money for things that they're not treating, whether that's heart conditions or
Right.
or other, some kind of brain disease, and they're just not
Right.
treating it. Yeah, right.
Right.
Yeah.
All right. I think we've covered the highlights of what to look out for in this enrollment period. So if you can remember all these things, all of you who are watching and listening,
Yeah.
and if you can't, go to the show notes and you'll get some links
Yeah.
so you can figure it out.
Yeah.
All right. I thank you for the Medicare part, and let's move on to the Obamacare or ACA part,
Yeah.
Affordable Care Act. And that will be for next month's episode, as the enrollment period for Obamacare plans begins November 1st and runs through January 15th. Our expert guide throughout is Dr. Stephen D. Culler, Associate Professor at the Rollins School of Public Health and Affiliated Associate Professor at the Guazetta Business School at Emory University in Atlanta. And I really, really do appreciate Steve taking all that time to come back and update us on all that's changed since last year. And I've put some useful links in the show notes. So I schedule one new podcast a month, as you probably know by now. So look for this next related episode on the third Tuesday of November. Updates on my show notes podcast page. I'd really appreciate it if you'd subscribe, of course, and share. We're on Apple, YouTube Music, Spotify, TuneIn, Amazon Music, iHeart, Podchaser, and my host platform, the Podbeam app. The video version's on YouTube, show notes and links on my website, www.stephanieshelton.com/conversations. If you like the podcast, please leave a review or give us a rating wherever you listen or watch your podcasts. Until I see you again, I'm Stephanie Shelton. Please take care of yourself and all those you love. Conversations on Health, How We Get There is produced and edited by Frank Harold. Research assistance from Dr. Richard Saltman, Professor Emeritus of Health Policy and Management, Rollins School of Public Health at Emory University in Atlanta.